You can start.
Good evening, participants. Thank you to join Shield Connect. Today we have a special guest speaker from Mumbai, and the name of the speaker is Dr. Shrutika Thakkar. And today she's going to take a webinar on the medical management of PCOS. And before we start the webinar, let me have a little introduction of our page Shield Connect. So let me share the screen, 1 minute. So you can go on shieldconnect.in page and you can see our page. You will find various sections on our page. The first section is the blog section, where you can find all the blogs written by the eminent experts, doctors and speakers. You can find various latest blogs also related to COVID, black fungus, and all the various topics related to gynecology. Then there is a webinar section. In webinar section, you can find all the upcoming webinars. So like right now, you can see the medical management of PCOS. When you click on this page, you will able to see the speaker details as well as the title of the webinar. Just you have to register, and then you will able to see the webinar of today. And this webinar is also going live on YouTube as well. And there is another page, awareness page, like we have two pages right now, immune booster and PCOS awareness page. In immune booster page, you will find our Regimen Mu, which is reintroduced by Shield in this respiratory pandemic situation. It is an immune booster. And we also have various blogs and videos related to COVID in this section. Then there is another page, PCOS awareness page, where you can find all the topics related to PCOS by various eminent speakers in different language like Hindi, Tamil, Malayalam, English. Then there is our leader page, where you can find all the speakers who are connected with Shield Connect. And there is a special page where you can find the day related pages. Like you can see the Hypertension Day, Mother's Day. So there is a GDM page. So you can find all the videos related to GDMs. So this is the Shield Connect page. And now let me introduce our speaker for the topic for today, Dr. Shrutika Thakkar. Ma'am is MS, DNB, done a fellowship in reproductive medicine and endoscopy. Ma'am is a medical director in Medansh Multi-Speciality Hospital and Medansh IVF in Mumbai. Ma'am is also working as consultant as an obstetric and gynecologist at Fortis, Jupiter, Hira Monji hospitals, or all are the very big hospitals in Mumbai. Then Ma'am is also managing council member of Maharashtra State Chapter of Indian Society of Assisted Reproduction. Ma'am is also youth council member of MOGS since 2015. Ma'am is elected as MOGS Yuva lead for 2020 and 21. Ma'am has done fellowship training in basic and advanced ART from Asuta, Israel, Homerton, UK, and Germany. Ma'am also be awarded by various awards. Recently, ma'am got an award for Best Youth Council Member Award for 2020-21. Ma'am was also awarded for Wonder Foxian Award in year 2019. Ma'am has also contributed numerous chapters in various textbooks, published it various scientific papers. And participants, if you have any questions, you can post your queries and feedbacks in the comment section, so we can have a Q&A session at the end with ma'am. So ma'am, we are very happy and privileged to have you on this platform, Shield Connect. And I will hand over this session to you. So let me stop sharing. I welcome you, ma'am.
Let me also congratulate Shield for the work that you correctly. Am I audible clearly? Or is my voice breaking?
Yes, it was breaking. You can start again.
Uh,
The screen.
we congratulate Shield for the wonderful work. Screen is visible, no?
Yes, ma'am. Yes.
Okay. Let me again congratulate Shield for the wonderful work that you all are doing in spreading awareness regarding PCOS, GDM, which is also very rampant in India and in the Indian population. And we definitely lack in awareness and lack in knowledge with regards to this disease, which still works as an enigma. So today my topic is medical management of PCOS towards better practices. How can we improve our practice to this reproductive disorder that literally affects the entire lifespan of the woman, right from the adolescent age group to the elderly. PCOS seems to have an entire spectrum of symptoms that affects the woman throughout her lifespan. And although hyperandrogenism and infertility are the most kind of troublesome or the distressing symptoms, and most often we see women only when they have this. But honestly speaking, it is something that even young girls need to be aware of. And today we are seeing that in the city of Mumbai, I get patients as old as 14 and 16 who have heard about PCOD from their fellow classmates, from their teachers, and they come to the OPD when they have irregular periods. And that is a very, very good thing. And that progress and that awareness, I think, is coming out of all such wonderful talks and CMEs that all you guys are holding. We all know that PCOS is a work in progress. Our understanding of PCOS has been evolving. The disease has been around right from 443 BC. In the prehistoric times also, there have been various kind of mentions about this disorder, and that this disorder has been around for a very, very long time. Different people have described it differently. Steen and Leventhal were the first scientists credited to a more accurate kind of a description. But till date, till the 2019-2018 guidelines, the international evidence-based guidelines, we still haven't been able to successfully define the disease. What we know in PCOS is honestly just the tip of the iceberg with regards to diagnosis, investigation, management. We still are learning, we still are kind of understanding, and there is so much probably that we are left to uncover. Today in India, we definitely are on the verge of an epidemic. Yes, the COVID pandemic is the most pressing thing on our mind, but there is really a PCOS epidemic that Indians are suffering from. And we see that globally only 2.2% of the population is suffering from PCOD, whereas in India, unfortunately, 1 in every 5 women seem to be having PCOS. Why is this happening? It is firstly maybe because as Indians, as a race, we probably have this genetic predisposition for diabetes, somewhere insulin resistance that we know is associated with PCOD. We are inheriting it genetically, and our lifestyle today, the lifestyle that we are following, aping the West, is somehow pulling the trigger. We are sitting on this cannonball and we are literally pulling the trigger by having these bad kind of lifestyle. When we talk about insulin resistance, we all talk about it very, very loosely, very vaguely, saying that yes, insulin resistance is associated with PCOS. But honestly, even scientists are not able to understand that what exactly and how exactly it is linked to this disorder. All we know that insulin resistance is very much evident in people with PCOS. We know that insulin acts in our body by causing glucose metabolism. Insulin allows uptake of glucose in the body cells. But somewhere this uptake is not happening properly in women with PCOS, and thereby there is a state of hyperinsulinemia. Insulin is linked to the LH. It somewhere controls the LH hormone secretion, and a hyperinsulinemic state is associated with having high LH levels. This high LH acts upon the theca cells of the ovary, and thereby it increases androgen levels. It increases the androgen secretion by the theca cells of the ovary, and this increased androgen levels cause so many of those symptoms that PCOD women suffer from. The hyperinsulinemia, the insulin resistance is also linked to having decreased sensitivity to circulating insulin, and we see that it is also very intrinsic to the PCOS mechanism. Somewhere it is also seen that there is a inositol deficiency that drives the PCOD pathology. There have been various papers that have been published by IVF practitioners, where they have evaluated the follicular fluid and the urine secreted by women who are undergoing PCOS, women undergoing ovum pickup. And they have always noted that there is an inositol deficiency in the follicular fluid. As an ART practitioner, I can tell you that the eggs retrieved from female who are women who are suffering from PCOS are somewhere not as good, or rather they are not as capable as the eggs of non-PCOS women. We always see fertilization defect, we see poor quality oocytes, and if we go back and study the literature, we know that inositol deficiency is probably maybe what is causing these poor quality oocytes. There is probably a insulin signaling defect that we see in PCOD women. This is still under research. We still need more evidence to know what is exactly causing this insulin resistance and how it is affecting these women. What we know at present is that there is a state of hyperinsulinemia. It leads to unutilized glucose. Probably that is causing more fat deposition in adipose tissue. So typically PCOS women, even those who are lean, if we assess the abdominal thickness, the skin thickness or the abdominal fat levels, we see that there is more fat deposition in the abdominal adipose tissue, thereby leading to obesity overall, or at least an abdominal obesity. All this leads to a silent, low grade, chronic inflammation state. And the reason why I'm discussing it is I want to emphasize about how this silent chronic inflammation affects PCOS women. All the studies, all the guidelines always emphasize that lifestyle modification is the number one treatment that we should tell our PCOS women. Always when a PCOS woman walks into my OPD, I spend 10 minutes literally talking to them about lifestyle modifications. I am talking from my clinic, and I can show you today that I have actually printed this whole pad which talks about diet changes and yoga asanas for PCOS women. It is very, very important to dedicatedly talk to these women about nutrition. It has to be a multidisciplinary approach. You should include your dietitian, you should include your exercise expert and counselor when talking to the PCOS women. And when required, we should advise them drugs like orlistat, metformin, myo-inositol, etc. to achieve that weight loss. Weight loss, even if it is modest, it improves all manifestations of PCOS. We see that when women lose weight, and roughly you have to give them a goal. You can't just say go lose weight. You have to give them a weight loss goal. What I tell my patients is try to lose 8 to 10 kgs of weight, or try to lose at least 5% of your body mass. So when you give the patient a goal, then it becomes more easy for the patient to understand. And how what is a good diet or what is a good lifestyle modification, how do we know it is working? If a woman is able to lose 0.5 to 1 kg per week weight loss, if she is able to achieve, then that diet is working. If that diet is not achieving that weight loss, then throw away that diet, don't follow that diet. That is what I tell my patients, that you have to find out what is your best diet, work with your dietitian to achieve zero point 0.5 to 1 kg of weight loss per week. If that is working, then that is your best diet. There is no particular best diet for PCOS women. Yes, high protein diet will work, it is recommended, but in our Indian diet pattern, where we are all mostly vegetarians, it is very difficult to achieve that kind of a diet, but it is a work in progress. You need to work on it. I want to here emphasize about the importance of gut microbiota. Like I mentioned before, somewhere there is insulin resistance, somewhere there is a role of lifestyle that plays a role, because suddenly we are seeing this epidemic. It is not that Indian genes have suddenly changed, but aping the Western diet and following a Western kind of a lifestyle has somewhere changed the gut microbiota. We are seeing that this is PCOS is affecting the new generation, women less than 28, 29, the millennials. They are seeing a very high incidence of PCOS. What has changed? Probably the gut microbiota has changed. When there is a increase in gut mucosal permeability, there is more secretion of lipopolysaccharides from gram-negative bacteria that may be affecting the gut. It may be inducing a chronic inflammation, and that might be interfering with insulin receptor function. This is what is thought by a lot of scientists. We really need more evidence to understand this pathophysiology more in detail. But because of these associations, the epidemiologists always study what is associated. So we are seeing that girls who are having a high fat, high sugar diet, a low fiber diet, in these girls, we see that there is an imbalance between the good and the bad bacteria. They are more obese, and somewhere this is probably leading to a gut dysbiosis. It is increasing bad colonic bacteria, leading to a leaky gut. Probably the natural immune system of the intestines is getting lost, and there is a silent inflammation that might be happening, which may be indirectly causing insulin resistance. So this is something that can be easily cured, and this is why I am mentioning it here right at the outset, because in one of the lifestyle interventions that you advise your patient, you can give them probiotics. It's so simply and easily done. Giving these probiotics and prebiotic treatment is a very simple intervention that we as doctors can do along with all the lifestyle interventions. Somehow a lot of patients are telling me that in PCOS we should go on a dairy free diet. Well, it is really, I don't know where this physiology is coming from. It is not like your dairy is bad for PCOS patients. Giving In fact, when I spoke to my dietitian, she's a registered dietitian, she said that there is no need to stop dairy. In fact, buttermilk and curds, which was usually a part of the Indian diet, traditionally we would end our meals with buttermilk. Somewhere today younger generation is not having that, and this buttermilk is actually a very rich source of probiotics and prebiotics, and it gives good bacteria to the colon. And maybe that is what we have changed in our diet, that pattern we have changed. There is a lot of benefit to giving these good bacteria, because they produce short chain fatty acids, and they increase colonic mucus production, they form more tighter junctions, and they reduce the passage of inflammatory lipopolysaccharide into the colonic lumen. And maybe by giving probiotics, we can achieve probably reduction in the inflammation in the colonic milieu, and we can return to normal ovarian function. So there are certain medicines that are available. There is alpha lactalbumin. The mechanism of action is that it enhances the epithelial barrier, it coats the intestinal mucosa, gives healthy bacteria, thereby increasing adherence of the intestinal mucosa, and it reduces this leaky gut phenomenon. So it and kind of rebalances the gut by dysbiosis, achieves eubiosis, and maybe this is also some kind of a lifestyle modification. I usually, when a person sees me, I usually give them this lacto-albumin sachets, and I give it twice a day for a period of 20 days. And I tell them that slowly, by using it for 20 to 30 days, you will see that somehow whatever other interventions that I am doing in terms of myo-inositol, metformin, they will suddenly start working better in you. And it is a simple intervention that we can do right at the start when we are seeing our PCOS patient. Management of PCOS women is definitely challenging. We still don't have perfect guidelines or perfect treatment for PCOS women. What we understand today is we should treat the symptoms. The cause is really not easy to treat, so we should treat the symptom. We should identify what the woman is coming to us, at what stage of her life is she coming to us. Is she a adolescent PCOS who is looking at regularization of periods? Is she a middle-aged female who wants fertility? Is it a secondary infertility patient who wants to have her child? Is it a young girl who is affected by the hirsutism on her face, or is it an old lady who is having irregular periods and who is at risk of endometrial hyperplasia and endometrial cancer? So kind of identifying some without the perfect management. We need to know one thing, that infertility and hirsutism cannot be treated together probably. Oral contraceptives are decade-old treatments which are given to PCOD women, but obviously the anti-ovulation and anti-androgens that are given for hirsutism are teratogenic. So we need to categorize a management, whether the woman is taking it for fertility. If it is for fertility, then ovulation induction is what we advise for our patients. There are various phenotypes of PCOS that we now know. There are various criteria that are there. right from 1990 to 2006 to the recent most 2018 criteria of the international evidence-based guidelines, we know that there are various phenotypes of PCOS that we can identify. The phenotype A, where there is hyperandrogenism, ovulatory dysfunction, and PCOS morphology. Then there is the Rotterdam criteria, which identifies all three, and that says that 2 out of those 3, if they are present, then also we can have PCOS. But basically, it is always useful to identify what phenotype of PCOS are we looking at, and that somehow helps us kind of modulate our treatment regimen, because honestly there is no satisfactory treatment regimen. All of those treatment regimens have good, bad, and they all have side effects. So we need to kind of taper, or right now kind of cater to whatever is required for our patient, and thereby have a better treatment modality. So there are insulin sensitizers like metformin, Myo-Inositol, that aid in weight loss somewhere, but they are if we ask endocrinologists, they are very happy to give insulin sensitizers. But the problem is that not all patients with PCOS probably have insulin resistance, and thereby as gynecologists we look at metformin and Myo-Inositol more skeptically. Most of the ASRM guidelines and ESHRE guidelines are keeping metformin and Myo-Inositols as a second line management, because they don't believe in this insulin resistance funda so much. I'm going to talk a little more about that later on. Oral contraceptive pills, yes, they aid in combating hypoandrogenism, they help in regularizing menstrual cycles, but as I mentioned before, they do not restore ovulation, they do not help in fertility. They are having an intrinsic risk of causing CVD, they increase risk of thromboembolic events, and they lead to weight gain. So it probably is like giving a medicine that could also complicate the disorder further. Ovulation inducers, we can induce ovulation, it can treat infertility, but it is not going to affect any other aspect of the PCOD like hirsutism and hyperandrogenism. Anti-androgens will tackle hyperandrogenism, but they do not restore fertility. So thereby we really don't have any perfect treatment or perfect modality of treating the symptoms. We really have to identify what is the pressing distressing issue that the person is suffering from, and then kind of individualize our treatment according to them. So if we briefly look at it, we have three pressing issues. One is irregular periods, one is hyperandrogenism, and one is fertility. So I'm going to talk about what are the available drugs, available treatment modalities that we have as doctors to manage these individual disorders. If your patient does not wish to conceive, and only if the problem is irregular menses, like if it's a young patient, say 18 to 19 years of age, or a 22-year-old girl who is not yet married and only wants regular periods, then our medical therapy is directed towards interruption of that unopposed estrogen growth. We don't want the woman to have periods every 6 months, thereby having endometrial hyperplasia and having bone loss. So thereby what we want, what can be given to the patient is simply norethistron therapy. We can simply break that hyperestrogenism impact on the endometrium by giving some progesterone for a period of 5 to 10 days and causing withdrawal bleeding. So that is what is the recommendation, that you should tell your patient that she should have maybe every 45 days she should have a withdrawal cycle. So teaching that patient that thing, that you, if you know that you are not pregnant, just take norethistron for 5 days and get a withdrawal bleed. That sometimes gives a lot of peace of mind to the patient, and that is probably the only intervention that you need to do. Unfortunately, gynecologists don't teach the patient this funda, and that's why patients keep on coming to the gynecologist again and again, saying that I did not get my period, or sometimes they get tired of not of visiting the gynecologist, and they simply accept that they will not have periods for 5 to 6 months. So that is really not a healthy way of functioning. We have to teach our patients how to cause withdrawal periods. We all know that non-fluctuating levels of unopposed estradiol in the absence of progesterone can cause irregular uterine bleeding. It can sometimes cause heavy menstrual bleeding, and it increases the risk of endometrial cancer. So it is never a good idea to leave the patient alone with having periods every 6 months or so. We should try and regularize these menstrual disturbances. The patient profile, if the patient is an obese girl, then we always have to be wary of the fact that OC pills are going to elevate the risk of CVD. They are going to cause dyslipidemia, and they are going to increase the chances of thromboembolic events. Excuse me. There are evidences that suggest that there is an increased risk of type 2 diabetes mellitus with OC without any kind of monitoring, and you can't say keep on taking OC pill for the least amount of estrogen as part of your oral contraceptive pill. We have two types of OC pills that are available in the market. We have cyproterone acid. So if which one should we select? So in PCOS, use we should use cyproterone. That is what I usually follow. Cyproterone acid is an anti-androgenic drug, whereas drospirenone has spironolactone kind of function. So in obese PCOS, there is a lot of bloating that is there. There are a lot of giving a spironolactone, which is a mineralocorticoid, helps in kind of the patient gets that initial 1 or 2 kgs of weight loss, and the patient is happier. It also has anti-androgenic effects, and that's why the acne, etc., also goes down. So spironolactone is something, or the kind of drospirenone is something that you should use in the obese PCOS. Cyproterone acetate in the dose of 30 milligram per day or 100 milligram per day, usually given is a combination of oral contraceptive pills. It inhibits testosterone production, reduces 75%, it decreases the testosterone levels, and it is a good drug for those PCOS who have androgenic influence, they have acne, they have hirsutism. For them, it is a very useful drug. There is also flutamide, which is an androgen receptor antagonist. It is given to women who have severe hirsutism. It is better that a dermatologist is involved at this stage. The most common side effect with flutamide is that there is dry skin, and is also associated with hepatitis. That's why it is not something that should be given by gynecologists. Flutamide as well as finasteride, which is an alpha reductase enzyme inhibitor. Usually, I prefer that this is prescribed by the dermatologists themselves. Ornithine decarboxylase inhibitors also, such as N-florentine. These are pregnancy category C drugs. They are available as facial creams for removing unwanted facial hair. But again, this is something that we should leave to dermatologists. Now, what can we do as gynecologists? Maybe we can prescribe Myo-Inositol. I'm going to talk more in detail later on about how Myo-Inositol is going to reduce androgen levels, but at a dose of 4 grams per day. It does reduce the androgenic influence. So always you should keep your patient's expectation realistic. You have to tell them that terminal hair which has got exposed to androgen, the existing hirsutism is not going to go away with Myo-Inositol, but the more the usually a good dermat will always work in tandem with a gynecologist, and even when they do laser, they always tell the patient that you should take some insulin sensitizer or Myo-Inositol to reduce the production of new terminal hair. So when they burn off the terminal hair follicles, they would always say that using an anti-androgenic drug will always be useful. So either you put the patient on OC pills, or if it is an obese PCOS, then my recommendation always is to give a Myo-Inositol formulation, which is going to reduce the androgen levels. When infertility is the pressing, distressing symptom, or when fertility issues are being looked at, we basically have two courses of action. We have medical ovulation induction, and we have surgical ovarian drilling. Honestly speaking, surgical ovarian drilling is something, as a fertility specialist, I do not recommend at all. It is definitely maybe second line, third line management, only reserved for those patients who have high LH levels. Because we see as fertility specialists that people who have undergone PCOD drilling, their AMH goes down, and eventually when they undergo fertility treatment, we get more poor quality eggs. So you have to very carefully select your patient for surgical ovarian drilling. It should not be done as frequently and as rampantly as unfortunately it is being done in our country. So what are we left with? We have medical ovulation induction. This is recommended as the first line of treatment by all the guidelines universally, by the ESHRE guidelines as well as the ASRM guideline mentioned that use of clomiphene citrate or letrozole is the right course of action. That is the first line of treatment that we recommend for our PCOS women. Letrozole may be tried but evidence is more in favor of clomiphene citrate for these women. There is also strong evidence that confirm efficacy of inositols in restoring fertility in PCOD patients. Unfortunately, all the guidelines currently mention that myo-inositol as well as metformin are second line of drugs. But you have to read between the line with regards to these evidence. We have to understand that which patients we should give myo-inositol and metformin. I'm going to talk a little more in detail about it a little later. But presently, coming to ovulation induction medicines, we have clomiphene citrate, which we can start as a dose of 50 or 25 milligram from second, third day or the fourth day. But you can't just keep on giving clomiphene citrate. It is definitely not for regularization of periods. It is always only for fertility enhancing. You have to combine it with follicular monitoring and planned relations or IUI, and we need to stop. Today we see that there is a clomiphene citrate overdose that is being happening. Every gynecologist that the person goes to starts again ovulation induction regimen. That is not the way to go about it. Totally, a woman should only have say 6 ovulation induction cycles, and if it fails to yield a pregnancy, then it is time to move on to the next modality of treatment, and by which I mean gonadotropins probably, and not letrozole. Totally, clomiphene citrate as well as letrozole should be used only up to 6 times. Letrozole has some theoretical advantages. Letrozole is definitely my preferred drug today because it does not block the estrogen receptor. It has no hypoestrogenic effect on the endometrium, and definitely there is a less chance of multifollicular treatment, and that's why clomiphene, more than clomiphene citrate today, we have shifted to letrozole. But in India, we see that our patients come to us saying that we don't want to do any fertility treatment, give us normal cycles, give us regular cycles, and we want to conceive on our own. What do we do in such cases? We need to tackle the insulin resistance. We have to evaluate our patients carefully. I always recommend, and that is what the guidelines also recommend, that we should take some time out and try and find out whether our patients are having insulin resistance. How do we do it? We can do the HOMA IR index. Labs like SRL and Metropolis, if you ask them to do the HOMA IR, they do it for you. Otherwise, it's simply done by calculating the fasting insulin levels and the fasting blood sugar. There is a formula. When the HOMA IR is about 2.5 or about 3, we know that the person has insulin resistance. And when the person has insulin resistance, then we basically have 3 drugs which are available. We have metformin, we have insulin, and we have inositols. If you speak to an endocrinologist approach to a woman with PCOS is very different from our gynecologist approach. Endocrinologists see PCOS as an endocrine disorder. They give metformin and myo-inositol only to patients who are pre-diabetic, who have hyperglycemia, whereas gynecologists, we tend to use metformin and inositols for ovulation induction. There is a difference in why this approach is different, because to a gynecologist, the patient comes and complains that I want regular cycles, I want to work on my fertility. Whereas when a person is going to the endocrinologist, they are looking at treatment of the metabolic syndrome, they are looking at the weight gain, they are looking at acne, they are looking at hirsutism, and thereby their approach could be different. But the crux remains the same, that these drugs are to be given selectively to tackle insulin resistance. So always, as we know, any medical management has its side effects. So selecting your patient is something that you need to be very meticulous about. Which patients to give metformin, which patients to give myo-inositol. I'm going to talk a little more in detail about it, but let us discuss the pros and cons of each therapy. Metformin attacks insulin resistance. We really don't know the mechanism of action of metformin is really not clear, in spite of metformin being around for last 30-40 years. We definitely have a wide experience in PCOD with use of metformin, but the cons are that it does not really prevent GDM, it does not affect the physiology of gestational diabetes mellitus, it is not tolerated by all, it crosses the placental barrier. Fetal risks are not unknown, although it has been categorized as category B drug by the US FDA. We really don't know whether it is going to impact the fetals in long term. Insulin definitely is not the preferred modality of treatment unless there is over diabetes mellitus. We really can't give insulin because obviously the patient is also not going to be liking to be on insulin. It is definitely not for PCOD. It is only for over diabetes. it can cause hypoglycemia, it causes weight gain, it can lead to large for gestational age babies. So only to be given in GDM patients who are not getting controlled with dietary management or not getting controlled with medical management. Inositols are the next drug which are available on the block since 2017. We have more and more evidence on the use of inositols. It is definitely something which is kind of mooted or suggested by scientists to be probably the more perfect kind of drug, because it not only prevents and manages PCOS and GDM, but it seems to be having a more favorable maternal as well as fetal outcome. The only drawback of inositol today is that lack of evidence. It is still considered as a nutritional supplement in the West. Indians, as Indian doctors, we are very poor in documenting our cases, and thereby, although Indian doctors have been using Myo-Inositol very, very commonly since 2017, we really don't have enough evidence, and the West is still skeptical about this inositol because for them it is still a nutritional supplement. Their drug association is really not recognizing this as a drug, and thereby our data that is coming in through the West is little slow. So really, I feel I really want to urge all of us gynecologists that we should have our own data. We should use the rich experience that we are having with Myo-Inositol, and we should come up with better scientific papers with regards to this drug. Metformin, we have decades of experience with this drug. It is definitely recommended in an obese patient. Even the ESHRE guidelines say that metformin can be combined for high BMI patients of PCOS. So in those phenotypical patients where there is hyperandrogenism and in obese hirsute PCOS, definitely metformin works. It is an insulin sensitization agent. It definitely increases ovulation frequency, but it is not the first line of action for ovulation induction, because the ovulation that we see with metformin is probably infrequent. Yes, if you put your patient on metformin, there are chances that the patient will start ovulating and the patient will get pregnant, but definitely it is not a recommended ovulation induction drug. So you can't suggest to your patient that start taking metformin endlessly and sooner or later you will conceive. That is really not the right modality of treatment. You should combine it with your ovulation induction drug, that is clomiphene citrate, letrozole, or gonadotropins, because there is a lower conception rate for ovulation in metformin as compared to all other methods. In high BMI patients, we should give metformin along with clomiphene citrate, because it also improves the quality of the eggs, and it also improves the insulin uptake by these patients, and it results in some amount of weight loss. So the hyperandrogenic milieu is kind of reversed when we give metformin. So thereby the response to clomiphene citrate is better. We also see that the chances of ovarian hyperstimulation reduce when we are combining metformin with ovulation induction drugs, and therefore metformin is definitely useful, but you need to know in which category of patients you should use your metformin. We as Indian gynecologists tend to have a one size fit all approach to our patients, and that is why the Western scientists criticize us. So what happened unfortunately with metformin is all of us started giving it rampantly to all our patients. That is something that we should now not do, and we should kind of steer away from that kind of practice. We need to be careful. We need to know that metformin can cause fatal lactic acidosis in those patients who may have some underlying renal failure. So you always should do a LFT and RFT before you start your patient on long-term metformin. We all agree that somewhere in PCOS, the overlying root cause is probably insulin resistance. There is an altered glucose metabolism physiology that is happening, and somewhere there is reduced myo-inositol that is present in the ovary. Now we all know that there are two drugs, myo-inositol and d-chiro-inositol, that is available. We probably don't understand it completely, but what we know today is myo-inositol is responsible. So myo-inositol is basically a precursor of inositol triphosphate in our body. So inositol triphosphate is an important second messenger in the body. It has a important role to perform in the cell messenger system, in the cellular messenger system, and in the uptake of glucose by the cells. Myo-Inositol is kind of directing the uptake of glucose in the brain and in the heart, in those tissues which are dependent on glucose, and on the other peripheral tissues where glucose is stored, such as the liver, the peripheral muscles. There probably inositol works through the D-chiro-inositol function. In the ovary, there is an important role of myo-inositol, and that's why giving myo-inositol supplement is very important, and it can probably treat PCOD in a good manner. Myo-Inositol is available in our fruits and vegetables also. Grapefruit, that is kharbuza or tarbuza, has a very high amount of myo-inositol. All the foods containing seeds such as almonds, walnuts, beans, that has a very high amount of myo-inositol. So telling your patient to include these things in the diet, that is a very, very good advice to give your patient. As I mentioned before, it is a secondary messenger in the human body. It has multiple functions. There are a lot of studies that are showing that myo-inositol is supposed to be present in the ovarian follicular fluid. Good eggs have high concentration of myo-inositol. I have 2-3 years back, I attended the ESHRE conference, and there were a lot of scientists discussing how we can use myo-inositol levels in follicular fluid as a test to determine whether the patient will get pregnant in IVF. So it is known to be an essential part of normal reproductive function. High levels of myo-inositol in follicular fluid is important for causing follicular growth and oocyte maturation, and it improves the oocyte quality. So when we understand that, we understand that somewhere the mechanism of myo-inositol, it is that it reduces the androgen levels. It probably improves the uptake of LH by the granulosa cells. It improves the LH receptors, and it makes the ovary sensitive to FSH and LH, and thereby it causes better follicular genesis somewhere in the ovary. So this we see when we give myo-inositol therapy to our patients. We see that when we give 2 grams twice a day, we see that there is better restoration of cycle regularity. Almost 88% patients have spontaneous menstrual cycles when they are on inositol therapy. 72% maintain normal ovulatory function during the follow-up period also, and around 30% of the patients have a normal ovarian rhythm within 16 weeks of this therapy. So it is something that we need to emphasize. Now, the only drawback is patients get bored. It is our responsibility as gynecologists at every visit to then boost and motivate them. And this is not a drug which immediately sees action. It's not like an antibiotic that when you have urinary tract infection, if you give an antibiotic, patient immediately starts feeling better. So here comes the role of counseling. We need to counsel our patients better. We need to tell them this physiology, how myo-inositol is acting, and we need to tell them that be patient, hang in there, and it will work. And that simple act is going to make your patient more compliant. We see that when we give myo-inositol, there is a 73% reduction in free testosterone levels. There is an increase in sex hormone binding globulin. There is a 65% reduction in high insulin levels. So all these positive things, these probably will help our PCOS patients, is what we are all speculating. What are the clinical evidences of myo-inositol? Since 2017, we are seeing more and more papers. We are yet to have one complete paper that says that yes, for sure it is going to affect PCOS, but there are a lot of randomized controlled trials which are coming up, and they all are showing a favorable outcome. In the year 2015, I happened to visit Homerton Hospital. As Mr. Nishant had mentioned, I've done a fellowship at Homerton Hospital, and I had the good fortune of meeting Professor Roy Homburg, who is a world authority, is a very famous scientist in the field of PCOS, and he has done a very, very large study on myo-inositol administration. It is yet to get published, but when I discussed with him personally, he mentioned that yes, probably myo-inositol administration in PCOS does work. They are seeing benefits of this myo-inositol administration in. So his recommendation was to give around 3 grams per day. In India, we usually say that you give 2 grams twice a day, probably because there is a change in the physiology of Indians as compared to Caucasians. But roughly giving myo-inositol decreases the requirement of both insulin, and it reduces BMI. So we see that PCOS women who are typically hyperinsulinemic, within 8 to 12 weeks of Myo-Inositol levels, the insulin sensitivity index increases, the HOMA index is improved, and this is what the new studies are showing. This is how to calculate your HOMA IR. You can do a fasting blood sugar, and you can do fasting insulin levels, multiply them, divide them by 405. If you don't have a lab which does HOMA IR for you, you can do it mechanically, and you can see that if it is above 3, then these patients are good candidates for giving metformin or Myo-Inositol. So this is something that you can do very easily in your OPD also. And it really impresses your patient when you do that calculation. So it is something that I regularly do. I write it down on my OPD paper so that it proves to the patient that yes, you have you have insulin resistance, and then the patient's compliance improves a lot. So doing that simple step is very, very useful. Giving Myo-Inositol administration positively affects hyperinsulinemia. It affects the hormonal parameters. We see that patients lose weight also faster, and there is better restoration of menstrual regularity. The metabolic as well as hormonal effects of Myo-Inositol have been studied in various double-blind trials, and they have seen that there is an improved insulin sensitivity in the group that is receiving Myo-Inositol, and it is seen by reduced free testosterone levels, and there is probably improvement in these hyperandrogenemic symptoms also when a person is pushed on Myo-Inositol. The kind of statistics are that there could be around 65% reduction in testosterone levels after 6 to 8 weeks of Myo-Inositol therapy, and almost 69% of patients on Myo-Inositol eventually start ovulating. We see pregnancies also, 40% pregnancy rates have been noted by the studies. 90% of these pregnancies have fetal heartbeat. So thereby this is a difference in metformin and Myo-Inositol therapy. With metformin, all of you gynecologists must have noted there is a high incidence of missed abortion when we give metformin in pregnancy. Whereas Myo-Inositol is something which is probably safer, and we see that the clinical pregnancy rates definitely improve when a person is on Myo-Inositol. So definitely the compliance is also better in Myo-Inositol, and we have a more clinical pregnancy rate and a safer delivery rate. Take-home baby rate is higher when Myo-Inositol therapy is given. It shows a significant improvement in metabolic characteristics as well. We see that there are less chances of hypertension, which is very common in PCOS group. So usually when I start Myo-Inositol pre-conception, I usually continue it because I also feel that it has a role in prevention of GDM. So I usually would continue it throughout pregnancy also. And usually the dose that I recommend is 2 grams per day of Myo-Inositol. Along with ovulation induction, Myo-Inositol is very, very useful because, like I mentioned before, it improves the intrafollicular Myo-Inositol levels, and we see better quality eggs and more fertilization rates when we give Myo-Inositol therapy. This is the consensus algorithm which was published in X-ray for ovulation induction in PCOS, and they say that in women with PCOS where ovulation is detected, we should just simply wait for natural conception. If ovulation is not detected, then giving clomiphene citrate or letrozole should be the first line of therapy. But the second line of therapy is gonadotropins or clomiphene citrate with metformin, or when not possible, then laparoscopic ovarian diathermy. IVF is reserved for those patients who don't conceive with this first line therapy or second line therapy. But inositols has not been mentioned in these guidelines, and the reason being is that the West follows evidence, and the evidence is still coming up. There are more and more papers, and I'm sure that in the next couple of years we are going to have more guidelines that suggest use of inositol effectively in ovulation induction studies also. With regards to IVF cycles, this is a very nice paper that has been published that says that at the end of treatment, the number of follicles of diameter more than 15 millimeters visible on ultrasound were significantly greater in the group treated with Myo-Inositol. That says that there will be definitely better follicular growth, better follicular genesis in the group that has been given Myo-Inositol, and also the number of M1 oocytes or GB oocytes are significantly reduced. So we always want M2 oocytes when we do IVF, and those numbers are definitely improved in the sector of patients who are on Myo-Inositol therapy. Definitely there is a role in giving Myo-Inositol in our IVF patients. It definitely improves oocyte quality. It definitely improves maturation. We see more 2PN, we see more cleavage rates in the group who are on high Myo-Inositol. And there are various papers. It is very interesting to read all these papers. In IVF programs, overall, we can conclude that there is a significant reduction in the number of immature oocytes, and there is a dosage requirement reduction that is seen in the patients who are on insulin sensitizers. And definitely there is a role to say that we should include it in our IVF patients as well. There are no side effects of this Myo-Inositol therapy. It is well tolerated by lean as well as PCOS patients. You can probably get mild GI side effects like nausea, flatus, and diarrhea. It is definitely safe in pregnancy. It is definitely beneficial in pregnancy, as I mentioned before, and it improves, it kind of prevents GDM, and that is one very significant improvement that we see. So as a ERT practitioner, we should not only concentrate on getting the patient pregnant, but I always tell the patient that it is just not being pregnant, it is about taking home the baby. So you have to, ART pregnancies always are high risk pregnancies, and you always need to do your DIPSI test. You always need to be wary about the increased risk of GDM, and we have to continue this Myo-Inositol and metformin throughout the pregnancy to prevent these disorders. Myo-Inositol not only improves pregnancy rate, it also reduces testosterone level, it improves insulin sensitivity, decreases insulin resistance, and it probably has some kind of role to play in prevention of metabolic syndrome in the later half of the patient's life as well. And like I mentioned before, I usually like to combine this Myo-Inositol therapy with alpha-lactalbumin because it improves the take-up of Myo-Inositol. And there are a lot of papers that say that combining it with alpha-lactalbumin improves the Myo-Inositol levels in the cellular follicular fluid and in the cells of the ovary. And it would be good to select a drug that has that alpha-lactalbumin as well. So my take-home message is, always have a patient-centered approach in PCOS. Not all PCOS are same. Classify, identify the phenotype of your patient. Spend some time in individualizing the therapy. We need to remain up to date with US advances in literature. We need to individualize our treatment depending upon the symptoms of the patient. If it is an obese patient, weight loss is definitely something that we need to talk upon right at the start of our therapy. If it is hyperandrogenism, hyperinsulinemia, those issues can also be very distressing, and they need to be looked at in every PCOS women, and then those symptoms also need to be addressed. When fertility is of requirement, then you should use ovulation induction agents, but also adjuvants like metformin and Myo-Inositol have a role to play because they improve the oocyte quality. PCOS patient can be the simplest patient to treat in IVF, and also it can be the most difficult patient to treat in IVF, and thereby we have to really fine tailor our ovulation stimulation and our ovulation induction. And as treating physicians, we need to be aware of all these difficulties and all the remedies and solutions at hand, and we need to communicate those to our patient, give them adequate support, prepare them for what lies in store, and help them overcome all the symptoms that come, all the health risks that come in association with PCOS. With that, I would like to end my talk, and all the questions from the audience are more than welcome. I hope I have been able to give you a good overview on all the medical management therapies that are available in the market. Over to you, Mr. Nishant.
Thank you so much, ma'am. This was very much informative topic from you, ma'am. There were lots of updated details that you have given to us today on webinar. So some of the general questions are there, let me start one by one. So does PCOS go away if the female lose weight? Ma'am, it is mute. Yeah.
So this is something that, almost every one of my patient will ask me, does PCOS goes away? PCO doesn't go away. So what I tell the patient always is, it's a lifestyle disorder. It's a lifelong disorder. So don't think that PCOS is going to go away. We have to address the symptom. If you want regularization of periods, yes, we will get regular periods, but don't ever think that your PCOS is going to go away or vanish from your body. So that is something you always have to emphasize. Right at the first consultation, you need to tell the patient, we are not trying to make your ovaries normal, or we are not trying to make the ovaries kind of not PCOS, but we are going to treat your symptoms only.
Then the second question is that nowadays most of the patients are like most of the females also are drinking green tea to lose the weight. So is green tea good in PCOS patients?
Green tea increases metabolic rate. So, I had done a Facebook live session with my registered dietitian, and we had discussed this green tea in detail. So now the problem with green tea is, yes, it improves metabolic rate. Why PCOS patients should take green tea, I can't understand, because the core issue, like I discussed during my slides also, is hyperinsulinemia. And green tea is
Yes.
really not acting on the insulin levels in any way. So honestly, green tea might help you, but it is really not the treatment for you in obese PCOS. Another problem with green tea is there are reports that say that increased green tea causes miscarriages. And in PCOS, where conception is itself wanted, and if it's so difficult to achieve, we don't want to take anything which is not safe for you. So green tea is something that I tell my patients that it's really not something that is important for you on your weight loss journey here. I would
Then
rather give Myo-Inositol to these patients, because then it will help them lose weight faster rather than
yes.
drinking green tea.
Do you recommend the patient that this Turoic acid is more helpful in adolescent patient with PCOS
There is no
who are
problem in
obese?
giving this Turoic acid to adolescent PCOS also. In fact, for my unmarried girls and for my
Yes.
young adolescent PCOS, I am giving these alpha lactalbumin
Mhm.
sachets, because I somehow feel, and that is what the international evidence-based guidelines are saying, that less than 18 years we should not brand our people with irregular periods as PCOS, because there
Mm.
is some potential to reverse these PCOS changes at that level in that age group. And if we see, gut dysbiosis is a new emerging funda. We really
Yes.
don't understand PCOS pathophysiology that well. If at all there is some chance that gut dysbiosis is the underlying mechanism of development of PCOS, it is
Mhm.
worth taking that effort of giving this prebiotic or probiotic to these
Yeah.
girls. So definitely, yes, in adolescent, in unmarried PCOS, in younger PCOS, this is a very nice therapy to give. So I definitely use it, and I have got wonderful results.
Okay, ma'am. And also some advice for PCOS patient like regarding the style.
So, like I told you, I actually have a printed thing
Okay.
I give to each of my patients. So there are a lot of foods which are useful in PCOS. So
Yes.
like red beans, legumes, having a high protein diet is
Mhm.
definitely useful for PCOS. Having more kale, having more spinach, these all contain myo-inositol. So essentially, what are we doing by telling them these diets? We are increasing the myo-inositol that comes through diet only to them.
Yes.
So natural
Yes.
supplements like red beans, like rajma,
Rajma.
lentils, they are very rich in myo-inositol, and we
Mhm.
can tell our patient to increase that. I also tell the patient to have a little bit of a less carbohydrate diet. So I tell them
Yes.
to avoid rice, I avoid potato, avoid sugar, avoid kind of having more fatty foods,
Fatty
because
foods.
weight loss is going to benefit. But it is not like lifelong they will not be able to eat rice. It is only in that interim period we should avoid that. Also,
Okay.
today we are seeing that younger girls are having more of refined flour in their diet. And
Yes.
as we know, the refined flour is something that is causing this gut dysbiosis. So I tell them to cut
Yes.
down on maida. I think following the Western diet, earlier we would not eat that much maida. Today we are having so much of maida in every.
Every food.
So I always tell them to read the food label. I was speaking to one a person who is a bakery person.
Yeah.
Digestive Marie biscuits, digestive biscuits. Honestly, if you carefully understand how our food FDA works, even if they include 20% the wheat coverage, even though they are using maida, if they are mixing
Yeah.
still they will label it as whole wheat biscuits.
Whole
So,
wheat.
so what I tell my patients is, why should you have biscuits as breakfast? You
Yeah.
should try and have something that you are freshly cooking. Have those 2
Yes.
chapatis instead of having that digestive Marie biscuit, because processed food is probably what is leading to that increased pandemic of PCOS in Indian population. So we should cut down on those refined flours. We should have switch over to healthier oils also. So refined,
Yes. Right now.
refined sunflower oil is something not which is not very good. So my dietitian in fact said, what is the harm in going to that kachi dhani oil that our ancestors were using? You know, the
Yes.
groundnut oil, the coconut
Groundnut
oil.
oil, filtered one.
Yes, because they are rich in omega-6 fatty acids. So it is
Yes.
very good. So those oils which are not refined oil are probably what is good, and we should use those oils only. Why should we even use olive oil for cooking? Our Indian oils,
Yeah.
coconut oil. If you listen to what all the highly paid dietitians, celebrity dietitians are talking, they are asking us to switch back to our older methods only.
Older methods. Yes.
Use more ghee in your cooking, use more older oils like groundnut oil or
Groundnut
coconut oil.
oils.
Don't use refined oil. So that is what I usually tell my patients.
Thank you so much for giving all this information on Q&A. And actually, it was very helpful session for participants as well. Thank you, participants, to join today's session. And I also thankful to you, ma'am, to join with us. We will also like to have more sessions with you in future. And I will also contact you further if I have any latest updates on the topics related to PCOS or anything. Okay, ma'am. Thank you so much.
It was a pleasure being here. You all are really doing a wonderful job. Keep it up. Thank you.
Thank you, ma'am. Have a nice day.